So one of the most important clinical signs of diabetes mellitus is polyuria and polydipsia. So in order to understand the polyuria fully, you first need to understand the physiology or the normal physiology of the kidney and of the nephron. So over here we have a very poorly drawn nephron and just a schematic of how everything is reabsorbed. So in your first part of your nephron, it's your proximal convoluted tubule, and over here you're going to have active reabsorption of all your major solutes, so your cations, your anions, your proteins, and all your glucose, ideally. However, in the case of diabetes mellitus, you're going to have a high concentration of glucose in the blood, and therefore a high concentration of glucose in your proximal convoluted tubule. Now, glucose is actively reabsorbed from the proximal convoluted tubule by transporters. Now, if you have a high level of glucose in your PCT, then you're also going to have saturation of these transporters. If you have saturation, then you're going to have glucose left behind in your proximal convoluted tubule. Now, the significance of your solutes being actively reabsorbed is that they establish a concentration gradient, and this allows for water to be passively reabsorbed from your lumen of your nephron into the surrounding tissues and blood vessels. If glucose is left behind in the proximal convoluted tubule due to the transporters being saturated, this gradient is not going to be established adequately, and therefore you're going to have water remaining in the proximal convoluted tubule and in the nephron in general. This is going to result in water being excreted by the kidneys, by the nephrons in the urine. So now I'm going to explain the process of insulin binding. Over here you have your insulin molecule, which binds to your insulin receptor, specifically the alpha subunit. Once it binds, it's going to phosphorylate insulin receptor substrate 1, and that's going to cause a cascade which results in glucose 4 attaching to the cell surface, which allows glucose to enter the cell. Now, in type 2 diabetes mellitus, you have three types of insulin resistance. You can have pre-receptor. In this case, there's a defect with the insulin. Either not enough is produced or it's defective. Secondly, you're going to have receptor-based insulin resistance. Over here, the insulin binds to the alpha subunit of the insulin receptor, but the insulin receptor does not phosphorylate insulin receptor substrate 1. You have post-receptor insulin resistance. The insulin is fine, the receptor is fine, so the binding takes place and the phosphorylation takes place, but there's a defect in the cascade. So everything takes place, but you're not going to have GLUT4 attaching to the cell surface and allowing glucose into the cell. Now, with very overweight animals, the high concentration of adipose tissue results in release of inflammatory cytokines and inflammatory mediators, and these inflammatory mediators damage the receptor. So with receptor-based insulin resistance, this can be due to high concentrations or high amounts of fat in the body.